Hey everyone, welcome to week 4. This is the week that we will be talking about assessments, and also your BPS assessment assignment has come out, so please make sure you take a look at that. It's going to be really important this week to review this lecture as well as the page with the BPS information, as well as watch the videos for how to complete the assignment, as well as there's also a role play set up that's optional for you to view on what the BPS looks like in practice. I understand that some of you are already utilizing this assessment method, and that's great. But for those of you who have not seen it in practice or haven't done it before, please make sure to check out that video. Awesome. So let's go ahead and get started. So by definition, an assessment is the process of gathering, integrating, and analyzing information to answer a question or solve a problem. In our case, we are assessing information to best treat the patient. So we are using this information to establish a treatment plan to determine what treatment modalities or what treatment functions are going to best serve someone. Sometimes some of us will use assessment to also diagnose. We will not be doing that in this class. So there are a couple different types of assessments. There are qualitative versus quantitative. So qualitative is more objective, and this is more done in a more verbal context, whereas quantitative is numbers. So that's when we're talking about standardized measurements such as the depression scale or an anxiety scale, which we'll check out later in this class. There's also formal versus informal. So in a formal assessment, we would see those standardized assessments. They're technically more reliable and valid because of the idea that we're using numbers, we're using scales. However, it doesn't really help justify the complexity of a person. So when we have informal assessments, which are primarily conducted via interview, whether that be with the patient, their family, whoever referred them to treatment, we tend to get a better and more holistic view of the person rather than trying to quantify them as a number. We also have structured and unstructured assessments. So a structured assessment, again, would have some type of quantitative component, and it would also very much so follow a structured format. And the BPS that we're going to look at is what we call semi-structured. Okay, so we don't use all formal modes of collecting information, and it is a semi-structured interview process because there are certain components that we have to meet during it. So again, the purpose of the assessment is to define and clarify problems and diagnoses, formulate case conceptualization. So again, that may be diagnosis, or to establish what symptoms they're having so that we can best determine the route of treatment, treatment planning, determining the level of care or the level of treatment that somebody needs, assessing client readiness for change, also to target problems and goals, screening, so to establish the severity of symptoms, tracking client progress to see if our treatment recommendations are working or if our program is a good fit for them, evaluating intervention outcomes. So again, tracking the progress, making sure what we're doing is helping, especially not hurting. And that also an assessment serve as an intervention tool. So when we have an assessment and we prompt clients to gain insight into their symptomology and their stressors and what's happening, that can really help them in moving towards change. So how we gather data for an assessment. So again, this might be through interview, either with the patient, their loved ones, their therapist, maybe their doctor, and in some cases, lawyers and police. And of course, many of these interviews will have to be done with consent. The only time that we would not need consent is if the patient brings this information on their own accord, or they are involved in some type of involuntary process, which we're not going to go into too much in this class. We can also gather data for the assessment through chart review. This might be from past treatment history at our treatment center or others. We will have to obtain a release of information to obtain records from other places. If another organization is referring the patient to treatment, they might send the records and collect the release of information from them beforehand. We can also gather data by observation. So this is by observing the patient's responses to questioning, their emotions, how they relate and interact with others, and of course their stories. Testing and measurements, so using standardized and evidence-based questionnaires or other assessments to measure symptoms. So that would be that quantitative piece that we typically do use in conjunction with a biopsychosocial assessment. So some different types of assessments, a problem assessment, so that is very quick and straight to the point. What's the problem? What are you experiencing? How can we fix it and find a solution? Behavioral assessment, so this is when, again, we are observing or assessing through interview or standardized testing client behaviors and how they engage with the world. We also have psychological assessments, which may include personality or emotional functioning tests. This is where we're talking about symptoms, thoughts, and beliefs. We also have diagnostic assessments, and this is typically where we're using pre and post testing. So an example of this would be measuring their level of anxiety or depression when treatment starts, and then measuring it again when treatment is over, close to the end of treatment, to assess how their symptoms or how their problems have changed. We also might be doing assessments on their communities, their families, and their peers. Most of us have heard of ability test, aptitude test. So many of us took these types of testing when we were in high school. We also have interest assessments. So an example of this may be a couple of the assessments that we used during the self-care assignment. So we did, on the second worksheet, we talked about things that you might be interested in but haven't completed yet. And we also do assessments to assess for risk of self-harm, harm to others, suicidality, that type of thing, which we will look at later in this class. So we will specifically be using the biopsychosocial assessment, and this assessment is pretty widely used in the chemical dependency and mental health field. So typically these are qualitative, so we are using language and verbalization to collect information. We are also asking the client themselves about what happened or what brings them to treatment. And so that's a very objective approach. So it's not cut and dry, tangible. This is, we don't have any hard quantitative evidence as to why they're there necessarily. It's by patient report. It's also informal, which we touched on earlier, which means that it's not completely, the assessment's not completely done by quantitative standard assessments. So we are also using our objectivity as the counselor, as the therapist, or as the clinician or case manager to collect the information. It's also semi-structured, so there is a structure to it. We do cover biological, psychological, and social components. However, it's not formally structured in the sense that it can look a little bit different across modalities and across different levels of care. Why we use biopsychosocial assessments, so to best determine the patient's needs and to consider the case holistically. You'll see here in a few minutes, and especially in your assignment, that we are touching many different variables in folks' lives. And so we're not hyper-focusing or over-focusing on one small piece. We're kind of taking a holistic, wider view. Also, to determine any other variables that may be perpetuating the problematic symptoms, such as medical history or trauma history. So for instance, sometimes in elderly, we see that they have cognitive decline and behavioral changes with urinary tract infections. So we want to ask questions about medical concerns to make sure that we can rule out medical illness opposed to psychological illness. We also want to help determine if a trauma history is driving or motivating any of the current symptoms. So those are just a few examples. So again, the parts, the different pieces of the biopsychosocial assessment, we have the biological piece. So this is when we're assessing for any medical concerns. We're asking if they're using substances. We are talking about any health risks in the family or mental health diagnoses in the family, as well as any substance use, violence, that type of thing. Psychological, we're talking more about symptoms and emotions that people are experiencing. Any type of, we'll ask different trauma questions here regarding how the worldview has changed due to trauma or what kind of impacts that trauma has on somebody's life. We're also talking about cognitive and physical vulnerability. So talking about patient stressors, because what we know is that when people experience toxic stress, they have less bandwidth to be creative and to think critically. So we need to ask questions about that. We also want to know if they're experiencing any grief or loss. And this would also be a place where we could talk about past attempts of suicide, as well as any history of self-injurious behavior. The social part of the biopsychosocial is family history, so a little bit about the person's childhood, who raised them, how were they raised, where were they raised, what are the impacts of community and peers in their life, do they have a lot of supportive friends, do they not, do they engage in any community or religious or group activities, are they a part of any subcultures, do they hold on to any traditions, do they have any cultural influences. All of these things would fit under the social section. And so again, just a quick recap. So the biopsychosocial includes questions about medical or genetic issues, age, developmental milestones, or physical characteristics. And you are welcome to revisit the slide on your own. The psychological of the biopsychosocial includes questions about a person's mental status, their thoughts, behaviors, feelings, emotions, history of trauma or abuse. And then the social aspect. So we look at the social and cultural factors that affect the client. This would have questions that seek to obtain information about the client's past and current family relationships, friendships and social support, workplace stress, the quality of marriage, community involvement, church, religion and spirituality, and finances. So in completing the biopsychosocial assessment, there are 3 stages of interviewing. The first includes the social stage. This is where we really start getting to know someone. We start building a rapport and a therapeutic relationship with them, providing them with information about the program or about the services that we offer, as well as offering a safe space that we could work in. Then we move into the information gathering stage or the interview stage. This is where we start assessing the problems, having a dialogue or a narrative around the problems, the symptoms, any risks or resiliency factors that they have. And then we move into the summary or transition stage. So this is when we summarize back to the patient the information that we've collected, make sure that it's accurate. Sometimes these assessments are done under duress. There's a lot of reasons why folks might be concerned about seeking help with mental health. And so we want to make sure that the information that we have is as accurate as possible. We also want to incorporate effective interviewing techniques. So we will look at that a little bit here, but these are going to be more, that's going to be more of the information that you've learned in your individual and group counseling classes. And then we also want to make sure that the information is gathered through empathic communication. So we want to make sure that we're not taking too much of an authoritative approach. And we also want to make sure that even though we might have a long day or a big caseload on our hands. We want to make sure that when we are with a patient, especially during this stressful time for them, that we're really present and we're not rushing, and that we have the time and space to really be with them and hear them. So something to think about is that the assessment is also an intervention. So by asking these assessment questions, we are helping intervening by helping a client to reflect and develop a greater understanding about the problem. So I know for me, when I have some type of issue rolling around through my head, sometimes it's appropriate for me to journal or process it with friends or loved ones or a therapist, um, because for whatever reason, the way that we process through language helps us to better understand the situation. So this might be the first time that somebody's really taking a general look at their mental health or their experiences. And so this is a time, even during the assessment period, where we can see a patient have what I like to call this light bulb moment, where they either, you know, determine that they've been better at managing their symptoms all along and that they have the strength to really work through these issues. Um, yeah. And so moving on, how the client responds to the question becomes more data to integrate in the effort to understand the client. And also how we ask the question determines the answer. So we want to make sure that we're not using really technical terms or jargon. So something that I kind of mess up on a lot is when I'm asking somebody about their primary care provider, I say PCP, and everybody looks at me like, huh, thinking it's the drug. But really I'm talking about their doctor. And so we want to make sure that we're not using verbiage that is something that the patient's not going to understand or something that they may mistake as something else. Also, the style of question and the words and language that we use will influence the kind of answer we receive. So we want to make sure that we're asking open-ended questions, which we'll talk about here in a second. One of the major purposes of the biopsychosocial is to also assess risk and resiliency factors. So risk factors are factors that make the problem worse, and resiliency factors are factors that support and promote problem resolution. So an example of a risk factor may be a medical concern, it may be a cognitive concern, it may also be a relationship where domestic violence is currently present, the fact that they're homeless could be a risk, or unemployed. And examples of resiliency factors are that they have supportive friends or family members, they have jobs, they have community, they have social supports, they are able to seek support in the community when needed, that's accessible. An example of a resiliency factor might even be something as simple as having financial needs met. Okay. And moving on, so asking questions. So when we ask closed-ended questions, so questions that typically are answered by yes or no, it's hard for us to get an accurate description of the problem. So we want to make sure that we're asking open-ended questions that will lead to more broad responses so that we can better conceptualize or understand the patient's problems. So open-ended questions typically begin with how, when, or what. So for instance, what happened when your partner said that to you? Or how do you cope with anxiety? Or when was the time in your life that you were the most happy? Okay. So some of the other advantages to open-ended questions, so it's a more collaborative process. We're able to explore broad topics and we facilitate a more expansive client disclosure. Something that I did want to mention was avoiding why questions. Why did you decide to stay with your abusive partner? Why didn't you leave him or her? Or why didn't you take the job? Whatever the case may be, we want to make sure that we're not evoking feelings of shame or defensiveness, or the need to be defensive, excuse me, in the therapeutic relationship, at least not yet. Sometimes I find that asking why certainly can be beneficial, but that's a more advanced technique, typically not something we do the first day that we meet somebody and are conducting an assessment. So facilitating client disclosures, we want to make sure that we're actively listening, looking the patients in the eye, being present with them. I know that many folks do biopsychosocials on the computer when they're talking to somebody. I've seen that done really well, and a lot of the time I've seen that done really poorly. And so typically when I'm doing an assessment, if it's somebody who's been there before, I'll ask if they mind if I type while I conduct the assessment, but if it's somebody I'm just meeting and they seem a little standoffish or concerned or anxious, I will typically just use paper to write down the main points. The trick is that we want to be as subjective as possible. So I use a lot of quotations in my biopsychosocials. There is going to be some room for our objective response, or what we think, or what our thoughts on behavior is. But for the most part, we do want to capture how the patient views the problems and the symptoms rather than how we do. Okay. So we want to make sure that we space out our questions with restatements and summarizations and empathetic communications. So thank you for being here. I know this must be hard for you. Let me know if you need any breaks, that kind of information. We also want to use normalization. So we want to reassure clients that sensitive or difficult questions or topics are asked of everyone. So sometimes normalization, what am I trying to say? When it comes to questions about trauma, typically something that I want to normalize conversations about suicidality, about trauma, but I want to make sure that it's on the patient's time. And so typically when I'm first meeting somebody, and your programs might require something different from you, but I typically just ask general instead of specific. So for example, have you experienced any sexual, physical, emotional trauma growing up? And I try to document which kind of trauma or abuse they've experienced. But for the most part, unless we've developed a solid rapport and some trust, I don't ask specifics about trauma. And we really don't need to be asking about specifics unless we're planning to directly address that trauma or treat those trauma symptoms. So being careful about how we ask, but also trying to normalize taboo or stigmatized conversations. And this could just be a disclaimer at the beginning of a discussion, like, I just want to let you know, I really support talking openly about suicide, homicide, having hallucinations. This is a safe space for you to do so. Also using bridges, so linking statements that connect the presenting problem to the topic that the counselor is about to inquire. So for instance, let's say that they're anxious because of a breakup. We might ask about other specific symptoms and how they relate to the precipitating problem. So using bridges and linking statements like that. So exploring the presenting problem. So asking the patient why they're here, why they are seeking treatment. So chances are we'll have a little bit of information about a patient before we're sitting in the office with them. We'll know why they were referred to treatment or why they wanted to come to treatment. But even so, it is beneficial and highly suggested that you ask them directly. Sometimes referral sources can be lost in translation. So maybe the therapist, so maybe the patient agreed to allow their therapist to refer them to the program, but the therapist was, hold on one second. Okay. So hopefully, I'm sorry, I just had a disruption. Give me one sec. Yeah, so we want to make sure that the patient is able to describe why they're there in their own words, because sometimes, let's say that the patient agrees to allow their therapist to make the referral, and the therapist kind of puts their own spin on why they need a higher level of care or what have you, and it gets lost from really what the patient thinks the problem is. So asking questions like, what brings you here today? What would you like to talk about? What problems have brought you here? Or how are you hoping the program can help? Also, some questions that we need to ask to develop a thorough understanding of the problem is when it began, how long has it been happening, how often does it happen, how long do symptoms last, or how long do experiences last, and then the intensity and severity of problems. We also like to understand the situational factors affecting the problem. So again, if a family member is chronically ill, or they're experiencing domestic violence or job or financial insecurity, we want to know these things so we can thoroughly understand what's going on with them. We also want to know what they've done in the past to address symptoms or the problems that they're presenting with. So in assessing stressors, so we want to ask them about their problems and how these problems affect them. We also want to know how the client has been able to to cope with stressful life events, situations, or developmental transitions in the past. So I know that some people come into the program and they say they have no coping skills whatsoever, yet they've been coping with severe symptoms, let's just say, of anxiety or hypervigilance for prolonged periods of time. They've been coping somehow. And so we really want to emphasize that most of us are doing the best we can with what we have. And so providing empathy and some compassion for the way that folks have coped with their stressors can be empowering. Also assessing how the stressor is impacting the presenting problems. So how does financial stress play into somebody's anxiety or depression? What are their fears? We also want to know if the stress itself impacts the diagnosis. So there is a line between anxiety and, let's say, hypervigilance, which is that constant state of survival mode. And so, hypervigilance may be telling of a potential diagnosis of PTSD or other trauma-related disorder versus generalized anxiety disorder, for instance. So we want to know how the stress might impact a diagnosis. And again, we're not diagnosing in this class. We also want to, again, assess coping strategies and identify goals. So how has the client typically coped with the current problems or other ones? What does that history reveal about the flexibility and breadth of the client's coping skills? What does that history reveal about problem solving? And how do we fine-tune these skills? Okay, how do we fine-tune them or transform them to be more effective? So there will be a video. I know that many of us have worked with Stages to Change in the past, either in motivational interviewing or general counseling classes, but please see the video attached to this week's module if you're not very familiar. We're just going to do a quick overview here. So pre-contemplation, this is when folks don't actually understand the severity of their problem. Maybe they're in treatment because their partner has threatened to leave them or their family has conducted some type of intervention. The contemplation stage of change, this is when we know we have a problem, but we're kind of on the fence about doing anything about it or making a change. We see many folks coming to treatment, especially in my years as a chemical dependency counselor, working in medication assisted treatment. Um, we assist a lot of folks being in the contemplation stage of change. They're not quite ready to quit. They fear that they'll be sick or that they won't be able to make the changes that need to happen in order for a life of recovery. And so they're ambivalent about the outcome or making the change. Also, the preparation stage of change. So this is when we know that we want to make a change and we're taking the steps towards that goal. So many people seeking treatment will also be in this stage or calling and inquiring about treatment. We also have the action stage of change. So this is the ongoing commitment to an engagement in the change process. So we're actually taking action. We're actually taking steps towards change. And then maintenance is continuing and sustaining the new habits, okay? New habits and new behaviors. So to understand and identify the client stage of change, we have to assess the client's understanding of why they're seeking treatment. We also want to see how measure their ambivalence or openness or defensiveness about the problem or seeking treatment. We want to see how much accountability the patient is taking for the afflictions or the issues. We also want to know how much blame is being put on other folks. And then we want to know how motivated is the client about making change? What are they willing to do? Have they tried to make this change in the past? How has that worked out? What were the barriers? And this, the idea is this will help us plan the treatment process for them. We also need to assess social supports. So these are all of the relationships that folks engage in. Typically relationships are either going to harm or help. Of course, we have some neutral relationships, but the relationships that folks are going to be talking about in treatment are usually solely one or the other. And so we want to know who's supportive of the patient, who is not supportive of the patient, who is a barrier to recovery for the patient, who do they receive emotional and spiritual or social support from, and how much do they get that support? What's the availability or accessibility of the support? Also, how are conflicts resolved in the family or the household or the workplace? So that can be very telling of a patient's symptoms and how they're responding. Also, have there been any significant losses and how has that impacted the client? So significant losses in relationships, as well as any trauma that's happened in their relationships, anything that's affected their relationships will be assessed in this piece. So just a quick overview. So these types of, biopsychosocial assessments are the most commonly used in the field of mental health and chemical dependency. They may be combined with other types of assessments. So for example, where I work, we use the PHQ-9 depression inventory, as well as the generalized anxiety scale at pre and post-treatment to determine whether those symptoms have decreased or not. They also provide a holistic view of the patient and their case. And also biopsychosocial assessments are easily summarized to share with treatment plans. So like I said before, the case studies that y'all have are biopsychosocial assessment summaries. And so we're working a little bit backwards here where we would typically do the assessment and then write the summary. We're starting with the summary and then doing the assessment. But know that the case studies are formatted in a way that that is how it would be shared with your treatment team. Thank you all for listening. Let me know if you have any questions about the assignment this week. It'll be due in 2 weeks, so watch out for that. And next week, we'll be talking about treatment planning. Bye-bye.